All right, welcome everyone to Puentes. Thanks for tuning in. I'm Mario Sal, filling in for host Mac Bowen. And on today's podcast, we have a product of New Mexico's training system and a great doctor up in northern New Mexico, Dr. Stephanie Lucero. Dr. Lucero, welcome to Puentes.
Thank you so much for having me.
So to start off, tell us a little bit about yourself, about your background. What's your connection to northern New Mexico and your history training in New Mexico?
Sure. Yeah. Well, I was born and raised in Powauket, graduated Powauket High School. And then I went to college in Texas briefly and graduated from UNM. And then went to UNM for medical school as well. And then did my residency, my intern year at UNM in Albuquerque, and then my residency in family medicine here in Santa Fe.
Who were some of the mentors that you had up there, at UNM in Santa Fe?
So definitely, first and foremost, I would say Mario Pacheco. He is still practicing in Powauket. I had the pleasure of working with him for a few years. And I want to say it was when I was like a third-year medical student. We had this sort of like meet and greet with people from around the state, and someone pointed me out to him as someone who was from Powauket and was looking to do family medicine. And so he sort of sought me out and was like, "Oh, you're from northern New Mexico?" And I was like, "Yep, born and raised." And he was like, "You're interested in family medicine?" And I was like, "Absolutely." And that was sort of like a big connection. He really sort of like helped. At that time, he was the residency director of the Santa Fe program. And he really just sort of pointed me in the direction of this. I actually didn't know. I probably would have eventually figured out that there was a residency program up here. But up until that point, I thought my only option was to stay in Albuquerque if I wanted to stay in New Mexico.
And with Santa Fe, was it just being closer to home? Was that kind of one of the things that made you want to go to that program, or?
I definitely like the idea of doing like the rural training. By nature, I'm pretty introverted and independent, and I liked the idea of a program where you were sort of being taught to be more of an independent physician, sort of sink or swim, rather than relying on a giant team of upper level residents and attendings and that sort of type thing. Because I kind of subconsciously and a little consciously always wanted to be that sort of country doc that was doing my own thing and self-sufficient.
Okay. So kind of doing your own thing and kind of keeping that in mind, can you share the story behind Hometown Doc New Mexico, which is your DPC practice, our direct primary care model for those that don't know, and what inspired you to go that route?
So after I left residency, I worked for a large like multidisciplinary healthcare system. And that was really good because I got to work with a lot of people that I worked with during residency, and I got to work with Mario Pacheco, Dr. Pacheco, and that, helped me sort of grow my wings a little bit more. But the longer that I was in that system, I couldn't deny how much in my bones it was just not the right thing for me. I was never comfortable with sort of what I would call the norm model of medicine, which is, these sort of like 15-minute appointments, very like business-like, very, I would say, bland and superficial. I really just couldn't help, especially because I was working in a community that I was from, and I knew a lot of people, and I knew sort of where they were raised and a lot of like where they were coming from. It was really hard not to sort of bring that into the healthcare. And so, after working for this large system for a while, I started getting, I don't like to use this term, but I think doctors can relate. I started getting burned out like pretty quickly. Yeah. And I just was like, there's got to be something different. So I actually looked into doing this retreat with other doctors who were also finding themselves burnt out and just looking to see if there was any alternative ways to practice medicine and survive, let alone thrive. Because really, I think in residency, I don't know if they still tell you this, but certainly when I was there, the idea of going into private practice or anything outside of a large system was sort of sold to you as an impossibility, like you just wouldn't be able to survive.
Yeah.
And so I never looked in that direction. But once I went to this retreat and I saw that there was other great doctors out there doing great things and doing what they wanted to do, that's actually how I learned about DPC, or direct primary care. And I was sold on it rather quickly. I was like, this is great. We get out of the insurance system, you get out the middleman, like you have sort of your own flexibility to practice medicine the way you see fit. The downsides were that from what I could tell at that time, there was only one other direct primary care clinic in New Mexico at that time, and that was someone in Las Cruces, and it wasn't clear if they were doing specifically direct primary care or just more like a cash model. And so I was a little fearful of trying to sell this to patients because we're very much conditioned for this current insurance-based model. And but that's sort of where I learned about direct primary care. And then, sorry, what was the rest of the question?
So just in terms of, I guess, the not liking the in and out approach, right? Where you kind of like revolving door, get them in and out as quickly as possible. And I think especially that's a very important, right? You mentioned being from the community, and that's something that when you're from the community, you want to care for the people, you know, that you know, like you said, that
Absolutely.
you've seen before, families and all that. So with that in mind, like, it seems again like that DPC model emphasizes the importance of community-based healthcare. And just from your experience, how do you see this approach impacting patient outcomes?
Right, that's huge. I can say now that I've been doing direct primary care for like 5-ish years, that, you know, I remember them saying in residency that only like 8% of what we did as doctors would affect anything in someone's healthcare. And now I hope that maybe I've moved that needle to like 10%, maybe 15%. But I do know that knowing my patients on a first name basis, and, you know, they call me Dr. Stephanie, like some of them call me Steph because they know me. You know, I see them at the baseball games. I see them, you know, out in the community, and a lot of them knew me when I was growing up. And it's just so different when you just know the person and you see, I think, you know, for example, if someone comes in sort of the big box model and they have high blood pressure, it's like, okay, you need to do A, B, C, D and take this medication and bye, see you back, you know, in a couple weeks or whatever. Yeah. Whereas in a direct primary care model, it's like, I know this person and I feel more comfortable sort of digging in a little bit deeper to maybe what's behind their blood pressure being elevated, whether that's stress at home, you know, other sort of stressors, just life changes, just things like that my patients open up to me about, and I just know about them off the top of my head that just makes it totally different. So, well, I don't have the statistics on how much direct primary care changes outcomes compared to like a regular big box model. Anecdotally, I feel like if nothing else, I definitely have had patients say to me that they have told me things that they would have never told another doctor because we have time and space and that relationship. And that even if I'm not changing necessarily their healthcare outcomes moment to moment, their mental health outcomes and just knowing that there's someone there for them that knows them is huge.
You want to see someone that's from your community.
Absolutely.
And I think, as you know, putting it like myself in their shoes, I think I would want to have someone that's from the community that knows, okay, these are some of the, factors in this community that would impact my health. Right?
Absolutely.
Yeah.
Yeah.
Kind of touching back on something that you said, going into DPC, you mentioned burnout.
Yeah.
And I think that's really important that you recognize that, right? Like you recognize you were burning out because even that impacts how you treat your patients, right? And the care that you give. What would you say for someone that might be struggling with that right now?
So in the retreat, I learned, and this might not be a popular opinion, that a lot of time doctors are burnt out because it's almost like being in an abusive relationship.
Okay.
Where you're just being told to move the widgets along and you're not having that connection with your work or with your patients, and you don't have control. You really don't have control in these big box systems. And, medicine is an art. Yes, there's science involved, but it really is still an art. And when you're being told, you ask any artist, do they want someone telling them how to do their art? It's very similar. And so I think that's why so many doctors get burnt out, and especially in primary care. You are taking on a lot of subconscious trauma from your patients. And you're just sort of expected to treat them like widgets, Hi, I just saw you for this horrible, terrible thing, and bye, let me move on to the next person. And so, yeah, I think it's pretty obvious why burnout happens.
Yeah.
And, I think my goal, and I think the goal probably of this consortium, is to find sort of alternative ways where young students, want to go into medicine, because right now that's problem number one. No one wants to really do this anymore. It doesn't look as glamorous as it used to be. And two, to keep them there and keep them happy in what they're doing. And direct primary care allows for variety, a different schedule every day, flexibility in what I see and what I do, allows my patients flexibility. It's just more freeing.
Okay.
Yeah.
Yeah. When you see patients, what's the general consensus? Is it something where maybe they feel like, oh, hey, I can call you any time of day and get a hold of you? Or do you kind of set a boundary with them and say like, all right, I'm available from these hours to these hours?
Yeah. So generally direct primary care, it's like every other primary care clinic in that there's set business hours. Really, the biggest difference is that for my clinic in particular, I don't have anyone working with me. So you are directly contacting me.
Okay.
I have a sort of a communication portal system with my electronic medical record, and that's the main way that patients communicate with me. But they can call me for what I call primary care emergencies. But generally, yes, for urgent care or emergency care, I direct them in those routes.
Okay.
I don't have an x-ray machine in my office. I can't take care of fractures or other things like that. So it is still the basic primary care model. The difference is that you get more time with your doctor, and generally, you get appointments pretty quick. My patients can send me a message and the turnaround is generally in less than a day.
Oh, wow. Okay.
So, I have patients that sent me messages this morning. I've already responded back to them.
Yeah.
And that's just not something you can get in a regular system at all.
Yeah.
So, I really just tell my patients, you're not paying for the medicine. The medicine is free. The monthly membership is for convenience and the importance of the relationship and access. That's what the membership is for. The medicine is free.
Yeah.
You know, they're paying me so that I know how much income I'm getting.
Yeah.
Right? And the medicine's free. That's like not even, it's, you know, it's like the Netflix of medicine.
Okay.
I think that's a good way to look at it, right?
Yeah.
Some months you might binge watch everything on Netflix.
Okay.
And other months you might not watch anything, right? Or you might use it once a year. Who knows?
Yeah.
But it's there if you need it.
Okay. Yeah. No, that's a great way of looking at it.
Yeah.
Yeah. How do you determine your prices for something like this and how many members you take on? Oh, wow. Yeah, that's really loud. Okay.
So, we just got interrupted by the loudest air conditioning system ever. So, because there wasn't any direct primary care clinics like in my area or in really New Mexico, I just looked at what the prices were for other places.
Okay.
And I talked to some of the sort of what I would call founding doctors of direct primary care, one in Kansas and some other ones, just to kind of see like what they did. And essentially, in general, monthly direct primary care prices range anywhere from $50 a month to $150 a month for an adult.
Okay.
Kid prices are generally lower. And generally that accounts for sort of as many visits as you need. I started with a tiered system, which quickly got very complicated. And then I moved to $85 a month, which is what I currently charge.
Okay.
And so I was trying to keep it in a range of affordable, but not so affordable that people were just sort of coming and taking it for granted or taking advantage of the situation.
Okay.
And yeah, so I do know now, since I've been open, there's multiple other direct primary care clinics that have opened. Some have prices $100 a month. Generally, they're staying in that $85 range. I haven't looked lately to see what it is in Albuquerque.
Okay.
But yeah, and I think this is, I don't know if this is one of the questions, but I think this is a good time to point out the differences between concierge medicine and direct primary care, because I get asked that question a lot still. And concierge has been around for a long time, and it's more when you pay a monthly membership and the clinic or doctor bills your insurance.
Okay.
So whereas in direct primary care, there is no billing of insurance. It's just the flat fee. So in sort of your more fancier areas, I do know, like when I first started, I talked to a concierge doctor in Lake Tahoe who was charging like $1,000 a month.
Oh, wow.
And then, billed insurance on top of that. But like he was at his patients like beck and call, and I was like, okay, I can't offer that. So we're not going to go with $1,000 a month. It's hard because the market is so small. It's hard to kind of gauge like what the pricing should be.
Yeah.
But I've been set at $85 for a while, and everyone seems to be happy with that. Though my accountant would say if people aren't complaining about how much you're charging, you're not charging enough.
And that's the other side of it, right?
It's
like, trying to do good by everyone through treating everyone's health, and then you have the money side of it. Yeah.
Yes.
Yeah. And do you kind of adjust also based on like families? So do you have like family rates, and is that still $85 per person or?
Yeah, so I do $85 per adult, and then kids are $20 with an adult, but then I give them a $5 discount off of that, so they're really like $15.
Okay.
So it's a $5 discount for every additional family member.
Yeah.
Trying to keep it affordable. I do have some families, there's like 2 adults and 4 children, and that can get pricey.
Yeah.
But honestly, they wouldn't change anything. I think they just love, like when their kid needs a sports physical or something like that, like they can just pop in and it's not this big thing of like trying to get their kid in somewhere to get something like that done.
That's awesome. That's awesome that, again, you treat families right, and that they know that they can come to you for pretty much like their healthcare, and making sure that they know that they're going to be treated right.
Absolutely. I mean, it is called still family medicine. Last time I checked, I don't know how much family medicine is still going on. But my policy up until recently was that I would take on any family members of current members. And, I'm sort of overwhelmed with patients at the minute. So I've kind of had to put a hold on that. But yeah, I mean, having the family, I have multiple families in my practice, and that dynamic is really important.
Yeah.
Yeah.
In terms of getting residents to become educated on DPC and, as a potential career after they graduate, what sort of things would you think would be valuable to teach them?
Yeah. Well, number one, I think the elephant in the room and the first hurdle for a lot of residents is always paying off their student loans. So the first question is always going to be, well, can I make money doing this? And the answer is yes, you absolutely can. You might have to hustle, or you will have to hustle at the beginning. Otherwise, it's going to be really that very offhand kind of attending. I think in most residency programs at big institutions, I hate to use the word hand-holding, but there's a lot more hand-holding that goes on as opposed to more of a community residency, when a lot of those residents have to be a lot more independent, a lot quicker. The attendings really, there's still that see one, do one, teach one mentality for sure. And I think that's great. But for DPC, it needs to be see one, do one, teach one, teach one, teach one. They really need to get that repetition in to be comfortable doing things and making decisions by themselves. And then also, I think building a network of other doctors they can call on. Especially at a residency, you always, any doctor in some ways second guesses themselves still and wants to make sure they're doing the right thing. So it's always great to have that, build that sort of community around you of other doctors and specialists that you can call on.
In terms of rural health, I mean, what do you feel is the impact that you've had on your community?
The biggest thing by far is that I do home visits.
Okay.
And even though I've been doing home visits for years, people still are like, I can't believe you do home visits. So my policy is basically, if you are homebound temporarily or chronically, I will come to your house and see you. I also do hospice care, which is, of course, in the home. But that is something that patients just still to this day are like, I can't believe you're going to come to my house. They think it's like a movie. The novelty has worn off on me for sure. Yeah. Like I do love doing home visits. I mean, seeing where someone lives, someone who's getting, for example, like a joint replacement, and then you go see their house and they've got stairs everywhere and narrow, and I was actually alluding to a patient before we started about, I had a patient that was living by themselves, needed a replacement, didn't really have a community, was struggling with living in a rural setting because of access and transportation. And I actually got that patient to move somewhere sort of, I would say, preventatively before this person got to a point where they weren't going to be able to do that. And that is huge.
Yeah.
And then just sort of like, I'll go into people's houses and point out, like, you need to put fluorescent tape on that corner. Like, this needs to be, you need to get rid of these rugs, like, these are fall risks, things that they don't really even think about. But Yeah, so the home visits for sure are like, and I'm not saying, I don't know, I'm pretty sure there's a lot of direct primary care clinics out there that do not offer that, but in a rural setting,
Yeah,
that is huge.
most definitely.
I mean, I will say that I could probably stop seeing patients at my clinic and just do home visits and be just fine, because a lot of the aging population living in rural areas, for their adult children to get them out of the house or transport them anywhere. I mean, it is a lot easier just to have the doctor or the nurse come out to the house.
Great. That's great that you do that because, you're 100% right. I mean, all the extra work that has to go into something like that, and then when you have mobility issues, like I think one of the things that we do, I will say like my culture anyway, like Latino and everything, is we kind of look at our family as being our caretakers, right? So for them, we kind of have this expectation like, oh, well, yeah, you're going to understand how to move your grandmother from one room to another or get them in the car or get them down the steps. I mean, something like that is extremely valuable, especially in New Mexico and New Mexico's rural areas.
Exactly. I mean, that is the one thing about New Mexico that makes it so different than, well, I would say than the more densely populated states. I mean, even people who live on the outskirts of Santa Fe, driving into Santa Fe is a big deal.
Yeah.
And if you've ever been around an aging, demented, mobility, disabled person and tried to get them in the car to come to a doctor's appointment, let alone the dentist or something, which shout out, we need some mobile dentists out there. I have multiple patients that need mobile dentistry. I mean, I think this is, again, as the baby boomers age, I don't know if anyone's heard of this aging tsunami in healthcare that has already started, but care for the elderly and homebound is hugely needed.
Yeah. We're getting close to the end of our time, but, as we close out, I wanted to ask, what sort of advice would you give to residents that are looking at, doing their training here and then staying here because you yourself did you're from here, did your training here, stayed here. What sort of advice would you give to them?
I think keep your options open. Don't close those doors. Don't let anyone tell you what you can and cannot do. You just made it through medical school and residency. You're a pretty capable human being. And, don't be sold on there's one option, because there really isn't. And I think doctors have sort of painted themselves into a corner in a lot of ways with our options. And my hope is that for myself as a geriatric millennial and the millennials after me and those Gen Zers, that they will, like they are so good at doing, make new paths in the road and, just continue to offer other options in healthcare, so that maybe we can break out of this, in my opinion, very antiquated way of providing healthcare in our current system.
Excellent. Well, thank you very much, Dr. Stephanie, for joining us today. It's been great talking to you and getting to learn more about DPC and, the work that you're doing up here in northern New Mexico.
Thank you so much for having me.